It's clear so far? Okay, let's now move to the second anatomical entity of the uveitis, which will be the intermediate uveitis. The intermediate uveitis will account for only 15% of cases of uveitis, which will make it the least common cause of uveitis. Those patients will have chronic relapsing disease with insidious onset. The ocular inflammation concentrated in the vitreous. So the vitreous and the vitreous base are the primary site of involvement in such cases. And the vitreous base will be overlying the peripheral retina and the pars plana, which will lead to secondary also retinal affection, as we are going to show you right now. So what will be the pattern of the inflammation? The inflammation takes two characteristic patterns, or first of all, it can be like there is floaters, or it can take the form of snowballs or snow banking. The snowballs, these are snowballs. They are inflammatory cells which cause aggregation, leading to formation of these snowballs. Sometimes they are coalesce, or the patients will have inflammatory exudation. This exudation will accumulate at the inferior pars plana, causing what's called the snow banking. Snow banking, meaning that it is more dense inflammation or more intense inflammation. So this is what's meant by intermediate uveitis. It is inflammation where the vitreous is the primary site of involvement. So what are the causes? It will be also infectious or non-infectious. And it can, before infectious or non-infectious, it will be classified into idiopathic and secondary to systematic disease. The idiopathic intermediate uveitis, it is called the pars planitis. So idiopathic intermediate uveitis, it is termed pars planitis in those patients. So they will have snowballs, snow banking without systematic disease. Or the intermediate uveitis can be present with systemic diseases. Most of cases will be associated with posterior uveitis or panuveitis, such as multiple sclerosis, or no, multiple sclerosis, there will be no panuveitis, but it will cause intermediate uveitis. In sarcoidosis, Lyme disease, syphilis, lymphoma, there will be panuveitis. Fox heterochromic iridocyclitis will be intermediate uveitis associated with anterior uveitis. Okay, so we discussed some of these diseases. Fox heterochromic iridocyclitis, the remaining systematic disease will be discussed in the posterior idiopathic posterior uveitis. So we will discuss now the pars planitis or the idiopathic intermediate uveitis. So the pars planitis, it is the commonest cause or commonest form of intermediate uveitis, accounting for around 90% of patients with intermediate uveitis. Usually it affects the young adults, usually more in females than in males, and around 75% of patients are bilateral. It's also worth mentioning that pars planitis accounts for 25% of uveitis in children. Children or pediatric uveitis, 25% of cases will be due to pars planitis. It has an HLA association, which is HLA-DR15, and doesn't have any etiology. It is unknown, so it is a diagnosis of exclusion. So once you diagnose or once you exclude the systemic diseases such as MS or sarcoidosis or so, then you will finally reach a diagnosis of pars planitis. So what will be the clinical features? Those patients will have floaters. This will be the universal presentation for patients with intermediate uveitis. There will be also decreased vision. There will be a flare with few keratotic precipitates, anterior vitritis, snowballs, and snowbanks. Snowballs, collection of cells due to epithelioid cells or giant cells collection. The snowbanks, due to the position of the inflammation exudation on the inferior pars plana. So this will be called the snowballs and snowbanks, peripheral retinal inflammation of the veins, periphlebitis, hyperemic disc, but there is no chorioretinitis and no synechiae. One of the commonest questions asked in the parasymptomitis is the commonest cause of loss of vision. The commonest cause of loss of vision is cystoid macular edema. It is the primary cause of loss of vision, followed by the cataract. Also, there could be band keratopathy, retrolenticular cyclitic membrane, vitreous hemorrhage. Why the vitreous hemorrhage? Due to peripheral retinal neovascularization. So peripheral retinal neovascularization can also result in peripheral retinal fibrovascular tissues causing tractional retinal detachment, or it can also be characterized by exudative retinal detachment. So the treatment will be, the main indication will be the cystoid macular edema with reduced vision, and the treatment will be periocular and ocular steroids. We can also consider immunosuppressive agents and vitrectomy, cryotherapy to areas of peripheral retinal neovascularization. However, the cryotherapy can be a little bit controversial. So it will decrease the leakage, it will decrease the macular edema, but it can lead to retinal tears, which will causing retinal detachment. So this will be like a controversial mode of treatment. The prognosis of this case, it will be 10% of patients will be self-limited, while 90% will have a chronic uveitis.